Greetings from Chicago, Illinois at the American Society of Clinical Oncology. My name is Brad Monk. I'm a gynecologic oncologist from the University of Arizona Cancer Center, and welcome to Expert Perspectives on PARP inhibitors and improving the clinical management of epithelial ovarian cancer. I'm here with my two good friends and esteemed colleagues, Dr. Tom Herzog from the University of Cincinnati, Dr. Ursula Machalonis from the Dana-Farber Cancer Institute. Welcome.
Good morning.
Good morning. This has been a fantastic meeting. A lot of new data, and we'd like to focus here on PARP inhibitors. Maybe, Ursula, you can tell us about what PARP is, the mechanism of action, and what's the relationship between PARP and BRCA?
Sure. No, I agree, Brad. It's a really exciting time for ovarian cancer, and 2014 is a big year, and certainly hope to continue these really great results. So PARP stands for poly-ADP ribose polymerase. It's a really important enzyme. It helps to repair single-stranded breaks. I think of it as an ambulance that drives to the site of the single-strand break within the DNA. It gathers with it a lot of other molecules. And because if you actually inhibit PARP, the cell then depends upon other mechanisms of DNA repair, really requiring double-stranded break repair mechanisms. And that's where BRCA comes in. BRCA is a really important protein that helps repair double-stranded breaks within DNA. So the concept of synthetic lethality will involve a PARP inhibitor. So that inhibitor inhibits PARP, that enzyme important for single-stranded breaks, that then really relies on the cell to repair double-stranded breaks. So if BRCA is not functioning, so specifically in a patient with a germline BRCA mutation, that concept of synthetic lethality comes into play. Drug inhibits PARP, and you have an abnormal BRCA gene and thus protein, and the cell then dies.
But you have to know that she's BRCA positive. So Tom, who should we test for germline BRCA mutations, and how do we test for it?
Right. So, you know, we tend to, it's an interesting area because it's evolved quite a bit. And what in fact has happened is we've certainly thought that these mutations in BRCA occur more frequently in high-grade serous cancers. We also know family history is important in terms of determining who has BRCA. So I think for—
And young age.
Yeah, that's absolutely right. Mm-hmm. Young age of the development of tumor, multiple tumors,
right?
Breast, ovary, others. And so we sort of started forming what we thought was this subgroup where BRCA would be very high. What we later found was that indeed is true. However, we cannot ignore the fact that BRCA occurs in people who are not of Ashkenazi Jewish descent. It does occur in some people who have a family history that is completely unremarkable, and it certainly occurs in other histologies. So the current NCCN guidelines are actually to consider testing or to test anyone with epithelial ovarian cancer.
And that's certainly also the ASCO guidelines, the Society of Gynecologic Oncology guidelines. So all patients with epithelial ovarian cancer, even mucinous and clear cell, because you can find some mutations there,
that's right,
should be tested for BRCA germline mutations 1 and 2, and for two reasons. And Ursula, you said very nicely and articulately that it can help guide therapy. Mm-hmm. It's also a prognostic marker. These patients live longer and respond to platinum better.
And it affects their whole family.
And it affects their family. This is really the cure of ovarian cancer, right?
That's
Angelina
right.
Jolie has done enormous goodwill in really telling people that she has this in her family and letting us live the emotional trauma with her of having risk-reducing surgery.
Correct.
But that's the cure for ovarian cancer.
Right.
So
and I think there used to be this stigma
Right.
of testing and this worry that it would infect insurance policies. But as you said, Brad, it's super important to get tested.
And now you mentioned that 2014 was a good year. Mm-hmm. It was a good year because bevacizumab was approved in both cervical and ovarian cancer.
Correct.
But it was also a good year because PARP inhibitors were brought to market in December. And for our audience, it may not have dawned on you, but the GYN oncology space brought you paclitaxel, a new entity in 1992. Mm-hmm. Well, here we're bringing, as a group, not one individual, but as a very concerted effort, a new chemical entity, a new therapeutic option, December 19th, 2014. So it's FDA approved through an accelerated approval. Ursula, tell us about what the current label is for the PARP inhibitor olaparib, an oral medication.
Yep. So the FDA label is very specific. It is for patients with recurrent ovarian cancer. They have to have a germline BRCA mutation as detected by an FDA-approved test, and we can talk more about that. And then thirdly, they have to have received 3 or more prior lines of treatment. That's what the label is. It's based upon Kaufman et al. Data published just recently in the JCO, really showing that the response rate in this particular subset of patients is around 30 to 35%, with a duration of response of approximately 8 months.
It's good. So
Yeah.
34%, 7.9-month duration of tumor control. Now, but you said 3 prior lines of therapy. Tom, are those patients platinum sensitive or platinum resistant?
They're both, and that's what I think is a major misconception
That's right.
is that PARP inhibitors only work on platinum-sensitive disease, partly because the design of many of these trials has been in the platinum-sensitive maintenance setting, and I think there's been that perception that you really need to be platinum-sensitive to have a PARP, when in fact we're finding that a number of those patients, even in the Kaufman trial, were actually platinum-resistant.
Interesting.
Right.
Now, every medication has a side effect. Some people say this is not chemotherapy. It really is, but it's oral. The dose, by the way, is 400 milligrams BID. So they come in capsules. That's 50 milligram capsules in the morning and 8 at night. 400 milligrams BID. What are the side effects? What's the drawback?
Yeah. So the side effects have been gastrointestinal side effects as well as hematologic side effects. The GI side effects are mostly nausea, vomiting, some abdominal pain, some epigastric distress, some reflux symptoms, and occasionally diarrhea. Tom went over this really very well last night. The other possible toxicities are hematologic, and that's mostly anemia.
Right. So Tom, how do you deal with the GI problems or the anemia related to olaparib?
Well, I think one of the things that you really need to be mindful of is the fact that our patients who've now had 4 lines of, you're on your 4th line of therapy or more, are also going to have some GI distress.
At baseline.
At baseline, and you can see that in the Study 19 data, where you can also look at people not receiving a PARP but receiving a chemotherapeutic and compare, and there's certainly a background noise there in terms of nausea, vomiting, dyspepsia, and so forth. So I think you have to be thoughtful of that. But there is no question that there is largely grade 1, grade 2 GI distress that's associated with these compounds, and specifically speaking to the olaparib data. So what I think most people do that have a fair amount of experience with PARP inhibitors is support our patients. You said it very well last night. I think it's a great way of doing it, is actually give them the prescription for ondansetron or some type of 5-HT blocker. You can also give them something for diarrhea in case that were to occur, and they can fill these as they need to.
And maybe Protonix or H2
Sure, those work as well.
Right, exactly.
Absolutely.
Right.
And so I think that's the first step, is really try to support them through
proactively.
Maintain,
Yeah.
absolutely, and try to maintain the dose and schedule that we've seen, because there does appear to be a dose effect from the studies that we've seen when you compare 400 to 100 and 400 to 200 milligrams BID. Still has activity, but we may be compromising activity if we immediately go to dose reduction. The dose reductions that they talk about are twofold. The first dose reduction is a 50% decrease to 200 milligrams BID. Second is another 50% decrease to 100 milligrams BID.
And these toxicities generally happen early, okay? And dose delays don't mandate a dose reduction, and supportive care, I think you said it well. So Ursula, this is an accelerated approval. That means you have to do another study. In fact, there are 3 studies.
That's correct.
So tell us about the 3 ongoing randomized phase 3s, which are really to ideally lead to full approval.
Right. So SOLO 1 is a trial that's being done upfront. So newly diagnosed patients, germline BRCA, finished their chemotherapy with platinum and taxane. And at the completion of chemotherapy, 2-to-1 randomization of olaparib versus placebo. So those are newly diagnosed patients. Study is completed accrual. We're waiting results.
Frontline maintenance.
Frontline maintenance.
SOLO 1.
That's right. SOLO 2 is recurrence and maintenance. Again, in germline BRCA patients who have just on the heels of chemotherapy with platinum-based chemotherapy, again, a 2-to-1 randomization of olaparib versus placebo. And SOLO 3, which is just opened, is to hopefully recapitulate some of this data, at least for the FDA approval, is for patients who have platinum-sensitive recurrence, germline BRCA. They are randomized to olaparib versus treatment choice based upon the the treating physician's decision.
So Solo 1, frontline maintenance, Solo 2, platinum-sensitive maintenance, Solo 3 versus chemotherapy.
Correct.
Now, there are other PARP inhibitors, Tom. What are the other PARP inhibitors?
Sure, you have a number of them, veliparib, niraparib, rucaparib, all of which are under active investigation in a number of combinations, lines of therapy, and it is a really large data set to go through in terms of the number of studies that are currently out there. It's a very exciting area, but it's also a very competitive area right now.
This Solo 2 trial that you talk about, platinum-sensitive maintenance, and the niraparib, which is called NOVA, also platinum-sensitive maintenance, will probably read out within the next 6 months.
Correct.
So we're going to have a lot of more interesting data. We're going to have lots to discuss. And it's now combinations. You mentioned what combinations are out there that can be added to PARP inhibitors.
Right. So because of preclinical data showing synergy between PARP inhibitors and drugs that block angiogenesis, a phase 2 was launched using cediranib, which is an oral VEGF receptor 2 inhibitor, plus olaparib, showing some very intriguing randomized phase 2 results against olaparib alone. And that's really launched now to open several phase 3 trials in both platinum-sensitive and in platinum-resistant cancer.
You like it though, VEGF and PARP inhibitor together, right?
Yeah, right. No, it is good, and I think really opens up the whole field of combinations, doublets, triplets. One can even conceive of quadruplet therapies, of different therapies that are targeting high-grade serous ovarian cancer plus other histologic subtypes, really based upon the genomic complexity of high-grade serous ovarian cancer.
One of the most exciting things here in all of oncology, but also at this ASCO meeting, is immuno-oncology. Is there any rationale to combine PARP with checkpoint inhibitors and immunologic molecules?
Well, absolutely. I think this is something that we strongly need to look at, and you're right, that's really been a big boon in terms of how do you affect the tumor microenvironment. So there's been a great deal of attention paid not to just the tumor, but what's going on right around the tumor, and what's going on systemically in the immune system. And both of those things need to be addressed. Obviously, if we could turn our innate immune system on to cancer and recognize that it's a foreign entity, that would greatly help, and it would cut down on the amount of chemo and surgery and everything else we would have to do to try to eradicate these cells. So from a theory standpoint, extremely promising. From early results standpoint, extremely exciting from what we've seen. A lot of big splashes in other tumor types.
Yeah, at this meeting in the mismatch repair category, which is not exactly genetic instability due to BRCA, but close, in colorectal cancer.
And endometrial cancer.
And endometrial, but PD-1 is very active, and there's probably some synergy there. So I think this is an evolving field. I'd like to wrap up with some of your opinions about regulatory endpoints. It had been since 2006 since we had any drugs approved. We had this 8-year drought. And now all of a sudden we get 2. We get bevacizumab approved based on a 3-month PFS endpoint. We've always been told that it was overall survival. And now we even get an accelerated approval in olaparib based on response. Has the tide changed, Tom, away from overall survival for drug approvals?
Yeah, I think it has. At least I'm not sure the FDA ever was as proscriptive as the rumors on the street, if you will, in terms of this is what you absolutely have to do. You have to compare it against this as being the standard. You have to win on OS, and et cetera. Having said that, we've had some lack of harmony between regulatory agencies in the U.S. versus Europe, which has been interesting with some other compounds before the recent approvals that have occurred. And even speaking to the current PARP approval with olaparib, we have very different labels in Europe than we do in the U.S., which is interesting. I think they'll...
Yeah, the European label is maintenance.
It's maintenance therapy.
That's right.
Correct. Yep.
I do think they'll come together. As we get information from these other studies, and that'll be a good thing. But back to your point, as far as where we are with clinical trial endpoints, I think there's been a greater understanding of the sophistication of the data analysis and the statistical interpretation of that data for ovarian cancer patients, owing to the very long post-progression survival that they have.
Right.
And due to that very long post-progression survival, where you have confounding of so many other active therapies, you really can obscure an overall survival effect, which is really problematic. The other problem is just the practicality. You have studies that last over a decade, that cost hundreds of millions of dollars, and the field is just moving too fast, Brad, to have results in 12 years.
Can't do that.
It will be obsolete. So yes, I do think there's been a change to look at other things, but it's not just PFS.
Got it.
You know, even in Aurelia, you saw more activity.
Which is the bevacizumab regulatory trial.
You know, there's the CITES data that goes with it. It's a
patient-reported
patient-reported outcomes,
It's a combination.
tolerability. Absolutely.
Absolutely. So are we moving towards a composite endpoint? I think we are. We haven't quantified it yet, but I think from a regulatory standpoint, there's almost a quasi-composite endpoint going on where they look at PFS, they look at quality of life, they look at no detriment in overall survival, they look at the magnitude of effect, they look at also response, pros, everything.
Now, it's also all about unmet medical need, and heretofore drug development has been in platinum-resistant disease. This is now fourth line, so 3 prior regimens. Is this a new sort of set of patients, a new identified unmet medical need where further drug discovery can be done?
It absolutely seems that way, and I think it's based upon, you know, really PARP inhibitors are the first personalized therapy that have been developed in ovarian cancer, and hopefully we can push forward and be very much like breast cancer and melanoma and colorectal cancer, where you're really starting to see subsets of patients where you can identify best therapies for those patients based upon biological markers.
So I think fourth line and beyond is an identified subset, but I just want to highlight what you said because it's so important that it's a biomarker world. And this is the first 2 targeted therapies, bevacizumab and olaparib, but it's also the first biomarker. So, and to come back where we started, that it all starts with BRCA, that if you don't test for BRCA, then you're not going to really have the opportunity to use olaparib on label. So. This has been excellent. I appreciate you taking time away from a busy ASCO. This has been Expert Perspectives. Thank you very much for having us, and so long for now.